So we are live streaming this AGM. I'd like to welcome friends, our staff, our partner organisation, the Friends of LAS and everybody else who's come tonight. And I want to start by thanking those who've put this evening together for us, because inevitably these events don't occur without a lot of work from comms, from Maeve, from Lisa, from everybody who's done it. So thank you very much. And as I say, it's the first. So if anybody doesn't like the idea that we're being live streamed, this is the opportunity to leave us now. It feels a bit like that moment in a marriage where people say, do you know any just an impediment why these two should not be together? This is your opportunity. So I will go through the agenda, which is, it is our statutory duty to present to you our annual accounts a year in retrospect. So the year ending March 2018, so it's the April 2017 to March 18. And for that, we have to show you our standing accounts, which Lorraine Buse will do, our quality account, Trish Bain will do, and then Garrett will talk about the year ahead. After that, we will pause and take questions. And then you will see from what Garrett's told you that we are changing how we provide our services in quite a meaningful way, and we're delighted to be able to showcase our mental health services, initially with a presentation by the National Clinical Lead for Mental Health Services, and then by a trust and a mental health crisis cafe, and we have a video of a patient. And again, we'll take questions after that, and there'll be an opportunity to network. So before we do any more, I'd like to introduce my colleagues on the Trust Board, and I'm going to ask them to stand up. So you should have mug shots on your seat. So, but in the order, I think I should start here. Our Chief Executive, Garrett Emerson.
Good evening.
And you'll hear more from Garrett anon. Our Clinical Non-Exec Director, Bob McFarlane. Thank you. Our Director of Quality, Dr. Tricia Bain. Our Director of Finance and Procurement, Lorraine Buse. Our Non-Exec Chairman of the Audit Committee, John Jones. And our Non-Exec colleague who chairs our Infrastructure Committee, Theo De Pensier. And turning to this side, our Medical Director, Dr. Fenella Wrigley. Our Non-Exec for People and OD, Jane, me, nearly forgot your surname, Jane. Our Director of Operations, a paramedic by background, Paul Woodrow.
Evening.
And our non-exec with finance and investment, a chief exec background, also Fergus Cass. And then in addition, in the front row, we have Philippa Harding, our Director of Corporate Governance, our Director of... pardon? Information Officer, Ross.
Hello.
Our Director of Facilities and Estates, Bonita. And our Director of, I always call it People and OD, but that's probably wrong, is it now? Patricia. And these directors form with the other board members, the executive team with Garrett. We do have a couple of apologies from Sheila Doyle, a non-exec director, our associate non-exec director, Amit Kuti, and Jessica, associate non-exec, but the rest is full house. And you've got the mug shots. So last year was a monumental year for our service, with significant major events in London. And I'm not going to read them out to you, but you will have seen the media coverage. You will have seen the court cases. About 1,000 of our staff were involved in these incidents, and some of them were involved in all of them. And that was very stressful for them. And actually what we'd like to also say, for the people who have to read through the records in back rooms, also very distressing. So we are very proud of them, and we have been given a lot of praise and thanks by the public and by various people, from prime ministers to members of the royal family. But of course, it is only a small part of what we do. And we're going to talk tonight about the much wider work we do and the changing face of London Ambulance Service. So the other monumental thing about last year was, having been an organisation in special measures and having been deemed to be inadequate by the Care Quality Commission for all but our caring services, which were deemed to be outstanding, we've been one of only 4 trusts in the country to move from inadequate to good overall. And again, that is a big reflection on all of our staff. But I just want to look again at how things have altered, because of course people think about 999, but actually it's 999 and 111, and paramedics. And that's only part of it. And whether you're looking at an athletic team and having excellence, or you're looking at a frontline health service, there are a whole range of other services that make it possible for our paramedics to go out and teams to go out day in, day out across the year to provide excellent services. And some of those in the past have been neglected. And again, when Garrett talks about our strategy moving forward, you will see how actually whether our vehicles are ready to take, whether the vehicles are fit and they've been cleaned and they've got fuel and they've got the right kit is as crucial as whether we've got the staff and the frontline medics. And that's just a few of them. But another issue is about listening to our staff. And I think this is a key reason, combined with looking at all of those members of staff in each of the different functions, why we were able to come out as special measures. We used to give messages out to our staff rather than listen to what they were saying. So that has been a significant change, but we have put systems and processes around them. And that is about governance, good governance, and it's also about systems to provide quality care in a sustainable way. And another important factor is we needed to work with our regulators, stakeholders and system partners. And tonight, when we hear from mental health providers, you will see how we're doing that in one of our services. And it's a combination of all of those that got us to the position of good. And of course, we want to be outstanding, and that's the journey we are still on. Then we needed to look at values and behaviour. And my goodness, I think that anybody who runs an organisation will know that the board adopting values and behaviours and being able to mirror those right across the organisation at every level is so important. Garrett and the team have done a lot of work on that. The board has agreed them. We debated. We've changed them. With 5,000 staff working in over 70 locations, mostly in teams of 2, it's quite difficult to get that change in a sustainable way, but that is the journey we are on. We really believe that our values and the behaviours of all of us are what will make us outstanding in the longer term. So we also improved our performance in 2017-18, and it was a year when the ambulance targets changed. So we are the busiest ambulance trust in the country. We had 1.9 million calls to our 999. That resulted in just over 1.1 incidents that we had to respond to. That's an increase on the previous year of about 1.3%. And when we adopted the new standard in November, and for Category 1 calls, that's the most life-threatening, the standard is 7 minutes, and we hit 7 minutes, 17 seconds. By the time we got to the new year, which is a very busy period in London, we were at 7 minutes 09. And Garrett will talk more about how we've got better from there. And for the next category of patients, which is 18 minutes, we're hitting about 22, and we're much closer to the 18 now. But in London, over 50% of our calls fall into Category 2. So it's a very challenging thing for us to achieve. We'll talk more about 111 because at the point of this slide, 357,000 calls, that's when we had one 111 service. But now, moving into this year, we have 2. And so that number would look like 750,000. It's very significant, and we need to get the balance right between when you phone 111 and when you phone 999. And we're very proud of our clinical hub, which no doubt you'll hear more about, that we're going to be able to move forward with that to help people get the right resource at the right time and help the public to do that. And our 111 service, you'll hear a lot of criticism nationally about, well, all they do is refer to 999. But actually, we have the lowest level of referrals from our 111 service to 999 of anybody in the country. So it's work that we're working on, but for last year, we were very proud of that also. So some of our people highlights. We've talked about the major incidents that we responded to. We've adopted a new workforce race equality action plan with initiatives and targeted recruitment. And it's something that at this stage, I'm proud that we've started it, as is Garrett, but neither of us are proud of where we've got to. Last night I was at a chairman's meeting, and it is, as Melissa would say, who's our race equality lead, this is a marathon, not a sprint. But when we look at data of recruiting people, and we don't manage to recruit anybody from London, I think the statistic of the ethnic population is about 47%, Garrett, is that right? 47%, 48% ethnic minority. And then we look at our workforce, it does not represent it. And the reality is our staff are treating people who don't look like them, who don't come from them, and we've got to get better at it. And frankly, we have a history of not treating people in a way that would make them want to work with us. And that has to change. And we are committed to that. And so now there are all sorts of initiatives, like an ethnic minority person on each of the recruitment panels. We're looking at it in a very determined way, and we will change. And it is unacceptable to the board, and I know to Garrett and his team, that we treat people less favourably because they are from a workforce race equality background that isn't the same as some of them. So this is a very serious thing that we have to address, and we're working on. So we're proud we've started. We're not proud with where we're at, but we will get there. I think we are more pleased with the progress of integrating our 111 service into 999 and the whole system. And as we won the contract for North East London, started that in August, now we have 40% of London's 111 service. We're also really pleased about the expanding multidisciplinary team, that when you look at our clinical hub, who give advice to our call handlers and dispatch and our paramedics, we have mental health nurses, we have midwives. It's a much wider cohort working with doctors, GPs, to get that mix of expertise. And if I say to you, we get 10,000 maternity calls. We have about, what percentage of our calls, Garrett, are mental health? 8 or 9% of our calls. That's much greater than any part of the country. We need to have that expertise. It isn't okay any longer to do our best. We have to work with partners to get the right care pathway. We've talked about how we have improved, and it's again work in process, of listening to our staff. Our chief exec does roadshows. We're looking at how we communicate differently and listen to people's experience. And at our board, we alternate each month having a patient story and a staff story. Today we had a patient story, and we learn from those experiences. And they're in the open board meeting, so anyone can be there and hear that story. And then lastly, we did win, along with the fire service and the Metropolitan Police, the Woman of Achievement Award on behalf of all our women in the service, which was a great thing to see. So improving care with patients, one of the big issues for Londoners and for A&E departments is the long delay. So our staff get frustrated, but actually it's not good for a patient to be on a trolley. And with Fenella and Paul, they led working with NHS and NHSI and NHSE where the demand would be, and managing to reduce the delayed handovers and demand across London. And they're going to be doing more of that in the winter room with our staff this year. It may seem surprising to you that we would call this an achievement and in providing care to patients, but we've rolled out over 4,000 iPads to our staff. Well, why is that important? A lot of the people we see have got, either, as you will hear later, mental health issues, or they've got chronic diseases, they're older people. We need to be able to access their record, and that's the next stage, working towards that, and being able to have protocols online so that we can be consistent with our care. We've talked about, and you'll see more about, mental health nurses. If you're in the room next door for refreshment, you'll see our other services where we're working, and maternity and falls are two of those. We're treating more people in their own homes or near their own homes. And we lead or participate in a number of high-quality research projects, which are quite impressive and we're proud of. And then we've worked with system partners on a variety of pathways for people with urgent and emergency care conditions, and the advanced paramedics in urgent care is a major part of that. So those are some of the things we've done. And I now can't get the slide to go down. Where's he gone? Can you help me get to the next slide? I can't go. Maybe it'll go there, will it? The down slide doesn't want to go down. Thank you. I would now like to hand over to Dr. Patricia Bain to talk to you about our quality account.
Thank you, Chair, and thank you, everybody. I have the great pleasure of informing you of our really significant improvements around quality, which Heather touched on earlier. So just to say, the quality strategy and the quality account that I'm talking about tonight is in the foyer. There are printed copies there, and it is on the website because I won't be giving all the detail of that, just to give you some highlights. But I think the one thing I really want to do first is to thank certainly our staff, our patients and public, our commissioners, our regulators, who've really helped us enormously on this journey, because without them we wouldn't be where we are today. So that's the first important point I want to make. Heather pointed out our progress in terms of our CQC inspection, and clearly last year's inspection moved us forward. But I think this diagram really shows where we've moved from. It's over a 2-year period, from what was a very red picture to what is now overwhelmingly green and outstanding in care, which is really important for our patients. So we had very positive feedback from the CQC on the improvements we've made and the progress we've made on our quality agenda, certainly in terms of care, but also demonstrating good leadership and improved leadership in the London Ambulance Service, and specific mention to our services around mental health and maternity. So Bryony Sloper, Deputy Chief Nursing Officer, and Amanda Mansfield, who's our consultant midwife, do an enormous amount of work on that agenda. So just really now going to talk about our progress and our specific quality account priorities, which relate to a lot of the work we did and the improvements we made around CQC. So in terms of developing our pathways, the first one we focused on was falls. So what we have is a paramedic trained in falls management going out to patients who have falls. And that means that patients have the appropriate care, but more importantly, they're signposted to the correct pathway. So in that way, we reduce the risk of patients going to ED, going into hospital when that's not necessary. So we have made big improvements on that. We've taken that work forward into our pioneering services for next year. In terms of mental health issues, we have increased our resource around mental health. We now have up to 7 mental health nurses in the clinical hub, and they provide advice and support to clinicians operationally, people who are answering the calls when mental health patients ring, and that has made an enormous difference in terms of the support we give mental health patients. Again, that's part of our pioneering work. We're piloting it now, and we're already seeing really good results in terms of making sure patients with mental health issues are signposted to the correct pathways. In terms of learning from incidents, it's really important that we can't learn unless we report incidents, and we have made great strides in terms of our percentage of reports that we put through our DATIC system, which is our system we collate all our evidence against serious incidents, low, no harm, moderate harm incidents. And what we wanted to see was an improvement in our low, no harm incidents so that we can look at those, analyse them, and hopefully prevent incidents becoming and give moderate and severe harm. So we've improved our low, no harm proportion of incidents reported from what was around 45% of our incidents up to 90% over the year. We clearly have done lots of work with the CQC recognised, and certainly with Fenella and her team around learning from incidents. Lots of examples how we feed our learning from incidents into our clinical skills refresher training for all our staff, equipment, policies, etc. So again, recognised learning from incidents across the whole year. In terms of patients' experience, what we had was issues around operational staff completing the mental health assessment. It's a challenging assessment to make when you're dealing with patients in a very emotive environment. So we revised the tool that the staff use to assess patients with. We implemented the training in our clinical skills training, and I think we've trained over 2,000 staff already in terms of managing mental health and how you document that assessment. We've done training for specific groups of staff, incident response officers, team leaders, over 200 being trained. And we are clearly seeing a big improvement in terms of how we document and assess patients from what was a variable position at around 71%. Now it's up to over 90% assessing patients on a regular basis across all of the sectors. In terms of infection control standards, again, variation in our compliance against those standards. We increased our infection control team numbers by 4 members of staff. We introduced infection control champions, and we utilised technology and apps to carry out audits at various stations, and particularly in emergency departments. So again, what we saw last year was a variable picture. We're now seeing consistently over 90% compliance against our hand hygiene standards. In terms of access to our services, one of the groups that we do a lot of work with is our frequent callers, who are clearly patients who need support, need help, and some patients, they are ringing 60, 70 times a day. So again, Bryony, her team, worked in terms of working with the system, looking at high-risk areas where we get the highest responders to frequent callers. And for specific patients, we've seen a really significant reduction in the times that they call our service. We also increased our numbers of staff in that function by 5, and we hope over the year to then see a really significant decrease in our frequent callers numbers with the appropriate support being given. And as Heather has also said, our performance standards are more or less up to the top level. Nationally, we meet the majority of our performance standards for all our category of patients, and that's, again, has been a significant improvement, particularly when you know the major incidents that we had to manage, as well as trying to deliver that type of performance. In terms of clinical effectiveness, so we look at clinical outcomes for our patients. There is about 10, 15 indicators. We are meeting all of those. We had an issue in terms of our stroke care bundles. That is the number of actions you have to take when you meet a patient with stroke and how many times you provide those actions. So again, that has moved from what was around 65, 70% up to, again, 96% across most of the sectors. Where we still have issues and where we really need to focus our care and our attention next year is around those who have cardiac issues. Again, there is a cardiac care bundle that patients have to receive from our staff. And one of the areas where we see there is issues is around pain and analgesia. And we believe it's a reporting issue, but again, it's something we really need to focus on, and we will carry that forward. In terms of mortality and morbidity reviews, again, Fenella, her team, supported by the quality insurance team, review deaths, so maternity, child deaths. We look at all what we classify as unexpected deaths, and that's really difficult in an ambulance service who's having 3,000 calls a day, and a lot of our patients have already died when we arrive. So there's lots of work going on across the ambulance service in terms of how we define an unexpected death that we need to treat as either a serious incident or we need to review very carefully. We're also working with the Care Quality Commission on that, because now we have monthly reports in terms of unexpected deaths or particular incidents that we need to investigate. We proactively send our reports to the CQC, which they are very positive about. But again, still some work to do in terms of getting that into our learning and making sure we're looking at every incident in the way that we should. But good progress on that agenda. Engagement with staff. I think it's fair to say lots of work, Patricia and her team over the year in terms of trying to engage staff, completing our staff survey, enormous amount of effort. Thank you again to our staff. We had what was quite a significant response rate and the highest across all ambulance services at 54%. We did see improvements in working patterns, patient care and experience reporting incidents, but areas where we need to improve, and Heather has just talked about, is around violence, harassment and bullying and equality and diversity. These are about cultural change. They take time, but we will not stop focusing on that. And again, there is an enormous amount of work going on to improve that position, and we expect to see some movement in that position this year. Freedom to speak up is key. Our staff need to feel confident that they can come and report to a person, people, when they feel they've got concerns that they can't manage through any of our other channels. So we now have a Freedom to Speak Up Guardian, and who is working with Philippa Harding, our Director of Corporate Affairs, to take forward that very important agenda. So we are now communicating out to staff, making sure they're aware of the Freedom to Speak Up and they're using it. We monitor it at the board, and today at the board we agreed the Freedom to Speak Up strategy. So a big piece of work to take that forward over the next year. I'd like to thank the Patients Forum in particular, and all the other patients and public who help us in a lot of the work that we do. Again, our work with patients engagement was recognised by the CQC as outstanding. And this is just a list of some of the areas where those patients have helped us work with us to do, take forward some of our improvements. And one of certainly my key indicators for the coming year is to make sure that there is a patient member of public on every single improvement programme that we do. And again, thank you for those of you who've contributed to that work. I just want to quickly talk about what we're going to do over the next year. So a really positive picture. We've made positive improvements, exemplified by our regulatory inspections, and I think our commissioners would support that as well. But moving forward, we cannot stop. We have still a lot to do, and we need to focus on certain areas. So in terms of SAFE next year, we are implementing Health Assure, which is a system that will help us monitor where we are against our key lines of inquiry for the CQC. It's really important that we build that into our business as usual processes so that we constantly know where we are, where the gaps are, where there may be safety issues, where there are risks. And that's been taken forward by the quality assurance team. Improving hospital handover delays, as Heather said, we have improved that. A lot of the work we did over winter, I think if you want the stats, there was a 14% reduction in our 15-minute handover targets and a 30% reduction in our 60-minute handover. However, now we need to focus on our areas that we have control of, which is our handover to green, and that will be the focus of next year's improvements. We are still rolling out our secure drugs room. We still continue to work very closely and in a focused way on medicines management. It was one of our key issues when we had the first CQC report, recognised substantial improvement, but we still need to carry on working on that. And lots of work around cardiac arrest, defibrillator downloads, so again we can learn from those and train staff appropriately. We have already completed an independent review of our training, and we are taking forward an implementation plan over this year to make sure we are giving our staff the right level of training, the right resource, the right environment to make sure they can deliver their care in the way we want them to. We are developing, well, nationally there are new ambulance response, ARP, quality indicators. We are developing those and developing our data collection systems to report on them this year and next year. We have rolled out a quality improvement training programme which builds capacity and capability around taking forward our improvements and getting us into a culture of continuous improvement. Our first cadre finishes in November, and we will carry on doing rolling programmes on that. And the sector roster reviews are really important in terms of our staff, making sure they get the right balance and work-life balance, making sure they get the right shift patterns so that they can also deliver care. And Paul and his team are taking that forward currently. We will continue to work with our frequent callers. As I've said, we want to improve that situation even further. Again, patient involvement in everything that we do, all our improvement effort, and reducing the number of ambulance conveyances. That, again, is part of our pioneering services work for maternity. So, again, providing that clinical expertise to the clinic hub, to our operational staff, to make sure that when patients, mothers, do not need to be conveyed, they are not, and they're given the correct care at home or in another service. In terms of responsive, again, lots of work that we're doing around our operational model to meet our new standards. So again, Paul and his team are looking at the vehicles we have, how we provide the care, and the rosters, rest breaks, etc., will all come into that piece of work. And one of the areas we still need to really focus on is making sure that when our patients complain, that we respond to them in a timely manner and we respond to them appropriately. We have already started that piece of work, making sure we improve that particular aspect. And in terms of well-led, we will continue to make sure our statutory mandatory training is met. We have a big leadership programme now going forward. I think it's the first time the organisation has had a leadership development programme for middle managers and upwards, and part of that does include quality improvement. So again, getting into this whole cycle of continuous improvement and take forward the people and culture strategy, which is immense, which I think Patricia would agree, but lots of work done on that and lots of progress. So there are priorities for last year. We have made significant progress that has been assessed by the CQC, and really pleased to report that. We still have work to do. We will strive to continually improve, and we will take forward those plans outlined in our quality strategy over this next year. And I'm confident next year when I stand here, I will be reporting a very significant improvement again. So thank you very much. I'd like to introduce you to Lorraine Buse, who is our Director of Finance, who's going to share our annual financial accounts. Thank you.
Good evening, ladies and gentlemen. We're now moving into the statutory part of the meeting, and it's my duty and pleasure to present the statutory annual accounts for the year ended the 31st of March 2018. The full set of accounts are reproduced in full in the annual report, and there are some hard copies in the other room. And I'll also be available in the informal session afterwards if anybody has any specific points and questions on those. The overall position, the Trust reported a good financial position for the year ended, with a surplus of 5.7 million. As part of that, NHS trusts have a number of financial duties to adhere to, and I just want to take you through each of those. There are 4 statutory duties and 2 sort of best practice codes. So first of all, the capital cost absorption rate. This is the cost of capital and is effectively the minimum return that's required by the Secretary of State on his investment in trust assets. That is required to be between 3% and 4% per annum, and we had a target of 3.5%, and we achieved that. The second statutory duty is to live within an external financing limit. This is effectively the way in which the Treasury controls the Trust's sort of public expenditure within NHS trusts, and is effectively a borrowing limit. It's set at a maximum of 0.5% of turnover, which would be about a £15 million drawdown. Our target for last year was a drawdown of 10 million, but in fact we significantly improved upon that, and in fact we gave back 8.7 million of cash. Now that is primarily achieved because we benefited very much from a bonus scheme for meeting control totals. So effectively you get sort of double the amount of cash if you hit control total, and that's available as cash then to spend in future years. The third financial duty is a financial duty to break even over a 3-year period. And that's assessed on a rolling basis over 3 years. And our plan was actually for a 2.4 million deficit. And as I've alluded to before, we ended the year with a 5.7 million surplus. Now, we benefited from cash that we earned and were awarded at the end of the year through a scheme called the Sustainability and Transformation Fund. So that explains the reason for that significant improvement. But as I say, that is really good news in terms of sort of future planning. And I have skipped over one important point, which is leaving the best news. So we also, the final statutory duty is to meet our capital resourcing limit. This is known as a CRL in NHS terms. It is the way in which the Treasury or the Department of Health ensures that funds that have been allocated for capital are used for capital. And we had a target of 25 million, and we just slightly came in under that of 23.3 million. But I think in the context, that's over 90%. Actually, in recent history, that was sitting at between 40 and 60%. So actually, our ability to spend the capital on assets for the benefit of our service, I think that was a really significant achievement last year. The final two aspects, Better Payment Practice Code, both in terms of volume and value, are to pay our suppliers within a 30-day period. Now here you'll see that we achieved just under the sort of the best practice of 95%. And in fact, that was due to a one-off problem with our supplier, and I'm pleased to report that we have recovered that position. And when I'm standing here this time next year, I'll be reporting an improved position. So in summary, the Trust has achieved all of its statutory financial duties for the last year. And then the other aspect that I want to highlight is the auditor's view of those accounts. Ernst & Young were our auditors. They are required to express an audit opinion on the accounts, both in terms of giving that they give a true and fair view of the financial position, and also that they've been prepared properly in accordance with the NHS Act 2006. And I'm pleased to report that we had an unqualified opinion, so the auditors concur with those two views. There are 4 aspects to the opinion. First of all, that there's an unqualified audit opinion on the financial statements. The auditors also look at the accounts in the context of the whole annual report, and they in particular compare the information set out in our remuneration and staff report, and they have confirmed that those are consistent. Thirdly, the overall annual report and the other financial statements, importantly the governance statement, that what's being said in those statements is consistent with what's set out in the numbers, and they've concluded that they are. And finally, the auditors express a view on the value for money, and they conclude whether we have provided value for money by not saying anything. So in fact, if you get no report on that, then that means you have provided value for money, and I can confirm that that was the case. So just to conclude, we achieved all of our financial duties. We had an unqualified audit opinion, and I would like to commend these accounts to you. So that ends the statutory formal bit of the proceedings. I'd now like to hand over... Sorry? I'd like to hand over to our chair. Thank you.
Thank you. Because what our Corporate Governance Director did was earn her keep, because those of you who are avid followers of agendas will see that I didn't do item 2, which is to ask us to approve the minutes of the meeting of the AGM last year. And I gather there are 2 minor amendments, so could you please tell us what they are?
Yes, One is the end time of the meeting. It states that the meeting finished at 1:30. It didn't start until 2:30, so and just needs amending. And then in paragraph 8.3, borough should read boroughs.
Thank you very much. So with those amendments, can we, for those who are here, approve those minutes? Thank you. And I think that's probably mostly the board. Any members of the Patients Forum that were here last year? Yeah, I think so. Thank you very much. So I will now hand over to Garrett Emerson, who's going to talk about the more exciting things of what we're doing next. Garrett.
Thank you, Heather. Good evening, everybody. So our priorities for the future. So far, you have heard about the work we've been doing to ensure that we are well managed financially, well led organisationally, and that we provide safe, effective, caring and responsive services for our patients. The fundamentals of operating a good health service, being a health service provider, in whatever field you're working in. And frankly, you do not buy a seat at the table to talk about strategy and talk about your role in the wider system until you've got those fundamentals right. So last year was very much about making sure that we concluded the journey, if you like, to ensuring that the London Ambulance Service had all of those fundamentals right. Very gratifying that the CQC inspection that you heard about confirmed that in very large part and allows us to move on. So one of the very last things we did as a board at the end of last year was approve the strategy for going forward for the coming 5 years, something that we've been working on through the whole of last year, and adopt a new vision for the future of the organisation, built very clearly about building a world-class ambulance service for what I think we will all agree is the world-class city that we're fortunate enough to live and work in. We adopted that strategy right at the end of the financial year, and it is very much about taking the organisation forward and about the role that the organisation can play, not only in continuing to respond and provide outstanding care for the patients that we see on a day-to-day basis, but the role we play in the wider healthcare system in London, and focusing on an objective of becoming an integrator of access to urgent and emergency care services right across London, whether that is on the phone, on scene, or indeed increasingly online as we move towards making more of the opportunities that the digital world offers us. What we also did was take the opportunity to re-clarify our purpose as an organisation. You might say, pretty obvious what the London Ambulance Service do. Why do we need to clarify it? Well, we need to clarify it to make sure that we are taking account all of the people that we have to provide services for. And that's not just the patient, as you will see. Of course, we will be and we will continue to be about providing outstanding care for our patients. That is at the heart of what we do, whoever our patients are and wherever we see them in whatever format. But we also aspire to be a first-class employer for our people, 5,500 people whose livelihoods depend on our organisation and whose quality of life, to a large extent, and career opportunities and objectives depend on the way that we manage and lead and develop this organisation. There's a wider group of people too whom we have a responsibility as a public organisation to serve, and that is of course the tax-paying public at large, who pay for everything that we do as an organisation. We have a statutory duty as a public service organisation to ensure that we provide the best possible value for the people that we serve, and that's what we aim to do. And then finally, as I've already alluded to, we don't operate in isolation. We operate as part of a much wider healthcare system, both here in London and, of course, across the rest of the country, particularly in the work we do jointly with our ambulance service colleagues to ensure resilience and responsiveness for those elements of our service that we provide a component of a national response to. So four key elements to our purpose, 4 Ps, very easy to remember, and just to illustrate that, what I say now, I'm going to put in the context of those 4 Ps. So going forward, in terms of our patients, We are keen, and our strategy sets out the objective to play a larger role in not only 999 service, but also 111 and the developing integrated urgent care world across London. We were incredibly pleased to win at the end of last year, as Heather, I think, has already mentioned, the contract to provide the new integrated urgent care and 111 service for North East London. That went live in August this year. That's on top of the South East 111 services that we've already been providing for a couple of years now. And we have now also subsequently won a similar contract to evolve that service into a fully fledged integrated urgent care and 111 service, and we will be rolling that out over the next few months. That is a huge opportunity for us and a fundamental part of our strategy going forward, because it in turn gives us the opportunity to start joining up integrated urgent care 111 services and 999 services, particularly in relation to the clinical care and support we can provide, integrating the support services that sit clinically behind our 999 services today and already sit behind 111 integrated urgent care services. Joining them up will enable us to provide better and faster care for patients, will enable us to respond more efficiently and more effectively, deal with more people instantly on the phone, and understand better who needs onward transport, who needs to be seen by whether it's ambulance service provision or indeed any other type of healthcare provision. Enables us to start realising that vision that we set out in our strategy to start to integrate access to urgent and emergency care. And then allied to that, as you've already heard from the work that we have done, the other big theme in relation to patients in our strategy is around how we can evolve and develop the care and the services that we provide to the front line. And that's very much about developing more specialised, more bespoke services for our patients in those areas that we've already referred to, whether that's urgent care with the development of advanced paramedic practitioners specialised in enabling to do that, who can achieve very high levels of seeing and treating patients on the ground without them need to take them to onward care, whether that's in an emergency department or indeed any other form of care pathway. Falls, developing further our falls teams and so on, focusing on mental health, which I'm not going to say too much about now because that is the subject of the second half of our evening, but also focusing on maternity. You heard from Heather the extent of the maternity service we already provide and the opportunities that we have to improve the effectiveness of our care for mothers in labour, and then providing a better end-of-life care for the patients that we inevitably go and see who are nearing the end of their lives. All of this about improving care, getting better care, getting faster care, getting more appropriate care, and avoiding unnecessary conveyances to emergency departments. Not only because emergency departments are clearly under a huge amount of pressure in terms of the wider system, but also because actually nobody wants to go to hospital unless they have to. They'd much rather be able to stay in their local environment, in their local home, near their friends, near their family, near their support networks. So the more that we can eliminate the need to people to go to hospital, the better for patients and the better for the wider system. So all of that, I think, is in our strategy, is about taking forward improvements that will benefit the patient. Again, we've already touched a little bit on the focus on our people, our new people and organisational culture strategy focuses on a lot of areas, and we have an awful lot to do, as Tricia says. Both in recruiting and retaining our talent, we've made significant strides in terms of filling outstanding vacancies, particularly in relation to paramedics and latterly in relation to control centre staff, two areas that have been highlighted previously in CQC reports and which have been high on the Trust Board's risk register. There is a lot of work going on there that's now starting to breed significant results. Improving engagement with our staff, it's actually very challenging having a dialogue as a senior management team with 5,500 people who work 24/7 shifts, 365 days a year, and work out of 87 different sites across a city as complex and large as London. So developing our capability to do that has been at the heart of what we are doing and will continue to be. The fact that we are live streaming this annual general meeting here today with cameras and so on is in part to enable us to do exactly that, to give people who are either on shift or not on shift and at home can possibly get here to see or hear what we're saying live today, give them the opportunity to partake and become involved in the work and the business of the trust as a whole, and not just the business of dealing with individual patients in individual situations. There is a lot to do still, and again, we're working a lot in terms of improving the healthiness of our workplace. Musculoskeletal injuries are a particular challenge for us because of the physical nature of so much of the frontline work we do. There's work going on there. You've already heard something about the development of a proper leadership program, which will operate on 5 levels, ranging from aspiring people who are not yet managers, who want to understand the first steps in terms of going into management, right up to support and development for people at the top of the organisation to enable them to be equipped to transform and modernise and evolve and move the organisation forward. None of that has ever been done effectively before in an integrated, joined-up way at all those levels, and that's the real opportunity now. Heather has mentioned championing inclusion and equality. I'm just going to add my 6 penneth there in terms of the priority. As Heather says, London, one of the most diverse cities in the world, over 300 languages spoken, 43% of London's population from black and minority ethnic population. The NHS in London, also a very diverse organisation with similar levels of diversity in terms of total numbers. The London Ambulance Service, not so. 2 years ago, we stood at just 11% of our organisational workforce was from a black and minority ethnic population. You could take that and put that organisation in any other part of the country, in any other ambulance service geographical patch, it would look quite diverse relative to the local population. But in London, it doesn't. We have to change that. We are changing that. We are moving forward now. We are at 13.9%, Melissa. Today, we have a target to be 15% by the end of this financial year, 20% by 2020. We're moving forward. You may say that's still a long way from 43, but we have some particular challenges. Some of the people that we have to recruit from, particularly the paramedic workforce, the paramedic graduate population in the UK, for whom we recruit from nationally, is nowhere near 43%. There is a shortage of paramedics in the UK, and it is nowhere near as diverse as we need them to be to truly reflect our population. So there's a challenge there, but that's not going to stop us. So we have a challenge to improve the overall diversity of this organisation, and we also have a challenge to improve the experience of black and minority ethnic members of staff in the organisation. In common with many other parts of the NHS, the experience is often not as good in terms of the propensity or the opportunities they see in terms of career development, the propensity for them to end up in grievance processes and so on and so forth, and crucially to obtain senior positions in the organisation. We are nowhere near diverse enough as an organisation as a whole, but we are certainly not diverse enough at the top end of the organisation. They are all big, huge challenges. That is why Heather says this is not a sprint, this is a marathon. This is going to take us time, but we are making progress and we will continue to make progress. So I'll get off my hobby horse there, but I just really wanted to emphasise the passion and the commitment that we have for that particular element of our people strategy. And finally, of course, it is about making sure that we do recognise everything that our staff do, the wonderful things that they do. You often see the stories of what our frontline people do in the papers and the new television, because it's naturally interesting television. But let me tell you, all of the people that work in the back office of this organisation do things that are just as fantastic. I repeatedly tell the story of the lady who works down in the Deptford logistics stores, who I once spent a happy half hour with not so long ago, who explained to me how they go about packing all the bags that the paramedics take out on the road to do their jobs. And she told me with such huge passion that this was a life-saving job. It's a life-saving job because if she gets that wrong, and the right drug is not available in the right place at the right time for a paramedic or an emergency ambulance crew member on the ground to help save a life, that could be the difference between a good outcome and a not good outcome. In her words, these bags were her babies. And if I've got somebody in the Deptford stores, logistics stores, who can talk with the passion like that, I know that people in this organisation, wherever they are, whether they're in logistics, whether they're in fleet support, whether they're in IT, who incidentally, if you're wondering why we're sat here today in the London Fire Brigade headquarters, is because we have an office here too. Just above us is actually our IT department and our performance team. Everybody in this organisation has a passion and a commitment and a focus towards a single outcome. And that's truly one of the inspiring things about working in and leading this organisation. In terms of public value, integrating 999 and 111 call answering will not only provide better and faster care for our patients, it will also provide a more cost-effective service to the benefit of the people that pay for our services, our taxpayers. Pioneer services will help reduce unnecessary conveyances to hospitals, will deliver savings for our wider system partners, relieving pressure on them. Programmes of work that are coming up will reflect the work that we believe will shortly be published in terms of Lord Carter's review across ambulance services into unwarranted variation. We know there will be opportunities in the work that's been done. We know that because we've been working in conjunction with all our other ambulance services colleagues to provide benchmarking information which enables us to see where we're strong, where we're efficient, and where we are less so. So there are some significant opportunities there. And I'm really pleased to say that today we were able to announce, in conjunction with one of our neighbouring ambulance service, South Central Ambulance Service, a new partnership to actually start to put some of that into practice already, to work jointly with our neighbouring ambulance service across key areas like procurement of services and logistics and so on, and indeed opportunities to join up patient care provision. One of the big opportunities that we see actually is not in 999 services, it's in 111 services, where we operate similar types of integrated urgent care, 111 service, using similar equipment, similar control centre technology and so on. And of course, we know that in addition to the 8.9 million people who are London's population, who live here every day, up to 1.5 million more people come into London to work through commuting. And of course, many of them, most of them, live in the surrounding counties. They live in the ambulance services areas of our colleagues, like South Central. So the opportunity, for instance, in terms of working in 111 with out-of-hours GP appointments and so on, to actually say to a patient, which we can't currently do today, you're in London, you need to see a GP out of hours, but you might want to see them back where you live. The opportunity to work jointly is perhaps a huge potential for us going forward. So that's just the start, I think. We are not only interested in working jointly with South Central Ambulance Service, we also want to work jointly with some of our other ambulance services, CCAM and East of England potentially, and indeed others around the country. And we will do more as we go forward. But just returning to London, specifically for the fourth of my themes, I think one of the things that's really struck me in the year and a half or thereabouts that I've been fortunate enough to be in a position is the scale of the partnership working that we need to do. We are not the biggest NHS trust in the world by far, but because we operate across the whole of London as the only pan-London NHS trust, we have to engage and work closely with a huge range of people. I've divided them crudely into three broad areas. So within the NHS system, the wider healthcare system across London, that's immense in itself. 32 CCGs, 5 STPs, mental health community trusts, mental health trusts, acute trusts, NHS England, NHS Improvement, Care Quality Commission. And we have a number of priorities, a number of opportunities where we can work together, including developing the use of alternative care pathways that can take pressure off EDs, can provide better care to patients, reducing conveyance, I've already mentioned, and indeed reducing hospital handovers. And you've already heard some of the work that we're already doing. There is a lot more to do. But that's just one of the spheres, if you like, one of the worlds in which we have to live in. We also, of course, work very closely with our colleagues in the other emergency services, both here in London, and we couldn't get closer right now to our colleagues in the London Fire Brigade. As you see, we literally work cheek by jowl. But the same is true with the Metropolitan Police Force, and it is also true in terms of resilience and emergency response capability and other work increasingly around all other ambulance services around the country. Indeed, we couldn't have done what we did last year in terms of the response to all of the major incidents that we were unfortunately called to attend without significant mutual aid and support and help from our colleagues around the country. Joint working and collaboration between emergency services is ingrained. We have a statutory duty to do that, but we do it anyway. Then the third world that I think we increasingly have to live in, we have to recognise that the London Ambulance Service is a very significant and very visible part of London as a self. It's one of the iconic organisations of London as a city. There isn't a day that goes by when we are not in the media in some way, shape or form in terms of what we're doing. We are probably one of the most public-facing elements of the healthcare system. Indeed, I've taken to saying that some people may have historically thought of us as somehow the back office or the back door of the emergency service response in terms of taking patients away to a healthcare world. We are now moving, as you can see, to thinking of ourselves as the front door of the urgent and emergency healthcare system across London. We are the opportunity to join up those worlds. Historically, we have perhaps, it's probably been fair to say that we've lived somewhat on the periphery of some of those worlds. We haven't engaged to the same degree as we now need to do in terms of that wider London world, working with other big public sector organisations. We haven't necessarily engaged at the heart of debate about the future shape of the healthcare partnership in London. We now need to play a role at the centre of all three of those organisations. And what that diagram is trying to say is we've got to move into the centre of all of those worlds. We've got to be a little schizophrenic as an organisation. We've got to be capable of adapting and working in those different worlds and bringing people together, being an integrator in the very largest sense of the word with all of our partners. That's a huge responsibility. It's also a huge opportunity, and one I believe that will benefit not only the healthcare system but Londoners as a whole. So, finally, what will our strategy deliver? We're very proud, I think, of the strategy we produced. We believe it is very ambitious, and if fully implemented, it will deliver some transformational outcomes, both in terms of the experience and the consistency of service for our patients. It could see well over 100,000 patients less conveyed to emergency departments. We've set a challenging objective to move our current conveyance rates to emergency departments from just over 60% today down to closer to 50% 5 years from now. That is very challenging, and we've worked with commissioners now to set out a path, a trajectory to achieve that, looking at delivering all of the component things that are in our strategy. And it could deliver up to £36 million worth of efficiency savings, not to the LAS, I hasten to add, but to the wider system. And I say could deliver because a lot of this is not directly in our gift. It goes back to what I've just been saying. It can only happen, it will only happen if we're able to work effectively in partnership with all of the elements in that wider partnership world that we now to live in. That is why it is incredibly challenging. That is why it's an ambitious strategy. But I do believe it is a basis to take this organisation forward and build on the incredibly solid work that we've done over the last couple of years to make sure that the organisation is fit for the future. Thank you. Heather.
Thank you. So before we move on to hearing from mental health, national policy, and then the local services and the very exciting work that we're doing together, I think it's an opportunity perhaps to pause at this point and take questions on what you've heard to date on the more general things. But Garrett and colleagues, thank you very much for your presentations. So Pauline has a roving mic. So a few minutes just to say, are there any, there's a question over here, gentleman over here, and then Sister Josephine after that. Yeah.
Yeah, my name's Mike Roberts. I'm a member of the Patients Forum, and I'll also pass over to Sister Josephine. Could I do recognise the Vice Chair as well on that particular basis? A couple of points of positiveness and also some concerns, which I know the patients' body has. Very concerned because CCAM have got exactly the same problems. And it's a top issue about violence, harassment and bullying. Those are particular issues which CCAM have got. And I think you've agreed that they need to be tackled. The other key issue which has come out time and time again, because I'm attending the health events at Excel, and the situation with regard to BME, it has come up repeatedly. And in fact, there was an anecdote of one of the key people who went to a meeting with the Mayor of London with a room of 20 people, and only one was BME. So even at the top level in London, there is an absolute issue. So I commend the focus and direction of travel, but you really have to get a bit of a move on, I think, in relationship to the BME side, because it is quite woeful.
Thank you for your questions. I'm going to start on the BME and then hand to Patricia, and I might ask Melissa to comment. But just to say, last night I was at a group of chairmen of London Trusts talking about what we're collectively going to do, because it's a problem for all of us. And some actions were taken away from that to try and take it forward. But Melissa is our race equality advisor. Melissa, do you want to add to that before we go to the more general part? Would you like to have the microphone?
Quite loud though. Since I've started in London Ambulance, we have been on a journey, and some of that is about changing the culture of the organisation. So I'm not one who is, yes, I want us to recruit many BME staff, but we also need to make sure this is a place that BME staff actually want to work at and that we retain them. So there's two parts of this journey. Some of that is about our organisation. We've started right at the top. Garrett, myself and the Assistant Medical Director chaired a big meeting with our top 300 managers. It's 700, but there was 300 at the time, talking about race, and we spent a whole 2 hours doing that. In any trust that I've worked in London, that has never happened. So I think as an organisation, we've held our hands up very high and said, we have an issue, and the issue is for all of us to solve together, along with the Patients Forum. I go to the Patients Forum's meetings, so it's us working together and not saying that this isn't a problem. We are aware it's a problem, and there are many initiatives that we are taking forward. And I think your point is relevant, that this isn't an LAS thing, this is an institutional thing across the country. We are one of the at the forefront in the ambulance sector of trying to move that. When I started, we were the bottom of the ambulance sector. Now we're nearer to the top, so basically we're the worst of a bad bunch. But we've still got a long way to go, and with your support, yeah, we're getting better. We're getting better, and don't think that this is not discussed at every meeting, and Garrett definitely holds me to account at all of the performance reviews, so the pressure is on. Thank you.
And then I'm going to ask Patricia to talk about bullying and harassment.
Yes, so I guess I would just... Is this switched on? So I would just echo what Melissa just said, because we don't miss any opportunity to have the discussion about the work we've got to do around our BME colleagues, and both recruiting them and also making sure they have the best experience whilst working for London Ambulance, so that they actually want to stay with us and build their careers with us. So I would just reiterate that we never close our eyes without thinking about that particular aspect of the work that we do. In terms of bullying and harassment, no, we're not alone. Yes, there is widespread conversations across the NHS about violence to staff, both from, well, violence to staff from patients, but bullying and harassment both from patients and also from colleagues, and we tackle both of those aspects of our work. So we have, for example, put in place training across our frontline staff for conflict resolution training, to give them good techniques and tools to actually cope with that day in, day out. In terms of our own staff, we've taken a similar approach to tackling bullying and harassment as we do with our race equality work as well, and that is to start to have the big conversations, because it is about cultural change. So Philippa and the work that she's been doing with the Freedom to Speak Up, making sure that people feel comfortable that they can come forward when they are experiencing that in the workplace, and that we've got mechanisms in place to respond to what we hear. But also, just last week we had a bullying and harassment conference, which many frontline colleagues came to. We had external speakers coming to talk about some of the work that we've been doing, putting in place routes for informal resolution of conflict in the workplace, which can result in claims of bullying and harassment. So we've, over this past year, we've introduced mediation, external mediation, to make sure that we've got different mechanisms for allowing people to resolve conflict in the workplace without going to formal methods of doing so through our grievance procedure, for example. So yes, we've got a lot of work to do. And yes, it is one of the very important parts of our people and culture strategy to actually build that capability to make sure that everybody in the organisation works together to actually tackle that. So,
thank you.
Thank you.
Did I gather Sister Josephine wanted to come in next, and then, yep. Sorry, 1 second.
Thank you very much. Thank you, Chair. I just first want to say thank you so much for this evening. The reports are so positive. I would like us to give a round of applause to the London Ambulance, please. I think why I'm saying this is because we have, from the Patients Forum, have been with them along the journey throughout the CQC reports. So I know when we say there is progress, there is progress. There are two things, though, that I would like us to add in your language. You mentioned about your partners. At this critical time of finding alternative care pathways for our patients, for our public, I think the word support staff should be strongly embedded in your strategy document. The other word I haven't heard much about is compassion. The London ambulance is about compassion. It's not just about reviewing our policy documents. Let us review the way we respond compassionately to patients. I just want those two words to be re-embedded in your strategy.
Sorry, Sister Josephine, I didn't get the first one.
The first one is having your support staff or support services as key partners. For example, voluntary agencies, voluntary community groups are key partners in the delivery of services. And you haven't had them, I haven't heard it mentioned. I think they should be mentioned. And we should find a stronger way of working with those partners. They are very critical. Thank you.
Firstly, Sister Josephine, I agree with you absolutely on both those issues. I'm sorry if you didn't pick up. I was trying to articulate the role and importance of our non-frontline colleagues in terms of whether it's fleet and logistics support, whether it's IM&T, technology, the computer people, or frankly any of our non-frontline staff. We have about 3,800 frontline staff if you include our control centre people in that. So the remainder of the staff in some way, shape or form, and I include myself and I include all of my colleagues, are support services to that frontline staff. Our people and culture strategy is about making sure that everybody feels valued. I haven't had time to put it on the screen today, but if you go to the values, the new values and behaviours that we've adopted as an organisation in conjunction with the strategy, they, in large part, were about redrafting them to be focused on everybody who works in this organisation. Our previous values were great and enabled us to drive the organisation to make the improvements we have, but they were about clinical excellence, care and commitment. They were very frontline focused. So now we're not only about clinical excellence, we're also about managerial and technical excellence. We're about saying everybody in this organisation and our partners who work for us indirectly in terms of contractors, agency staff, and you name it, do that. And for the first time, in terms of the roadshows that I do twice a year, I'm about to start a new round of them next week, we will be going out and talking to those colleagues as well as frontline colleagues and as well as corporate head office colleagues. So you're absolutely right. And in terms of compassion, that remains. I think you only have to look at the work that we do and the incredible commitment of so many of our colleagues, whether they're frontline or not. The compassion is a big part of the caring. Caring can be interpreted as a clinical, sort of almost technical excellence in terms of the medical care that we provide. But for me, it's also about empathy, and it's also about the way that we look after our patients and the way that we treat them and the respect we have for them. And I think we are very good at that. There are occasions when we don't get it right. And in fact, one of those occasions was exactly the patient story that Heather was referring to this morning, that we reviewed in public session with an Evening Standard journalist sat in front of us in our board. So I think that in itself, and you may well read about it in the papers and so on in days to come, demonstrates the commitment that we have to getting this right and getting it right every time.
Thank you. Gentleman. Yeah, and then the lady at the back, and then we must move on to mental health.
Thank you very much. And could I just say this is a very good AGM, and it's really good. Far more people than came along last year. I think the rescheduling has been a really good idea. Picking up the slide that's still on the screen, on the second bullet point, the 122,000 over the lifetime of the planned period. Now, I fully appreciate that what Garrett mentioned, that the ambulance service is effectively funded by each of the London CCGs. So they're paying money into a pot that funds the ambulance service. But looking at this reduction, my understanding is it's roughly a reduction of 1 in 6 conveyances based on the current number of conveyances, 122 over 760. Now that, for any organisation, even in a 5-year period, seems to be a heroic aspiration, and obviously it ignores any growth pressures on the current base. I'm just a bit scared that what we could be looking at is effectively a commitment to the CCGs who fund the ambulance service that less money will be coming into the ambulance service by the end of this planned period, which is effectively a cut by stealth. I'm not trying to get into polemics. It's all about funding the health service, but I just wonder if the ambulance service can genuinely robustly deliver this very new target, which we need to spend a few years really checking it is deliverable at that scale before we start saying the ambulance service won't need that sort of funding from the CCGs. Because my experience, as we all have, of CCGs is they have multiple demands on their money, and they could already be building in a saving of their share of funding the ambulance service. A little bit rambly, but just a bit scary. Thank you.
You're right, and we need to be funded differently. I'm going to ask Garrett to briefly cover that. Because it's, as you know, a bit of a PhD sort of question.
Right, two or three very quick points in relation to that. In terms of the maths, the bar charts that you see there include the growth. So if you see we go up, if we go up in terms of maintaining at the same proportions as we have today, you end up with more conveyances. So that the 120 reduction is on top of the growth that you would have in the do-nothing option. So that bit is included. Second point I'd make, I'd take a point from the financial world and preface this with a warning that past performance is no guide to necessarily future success. But I would just draw you to one statistic. 8 years ago, the proportion of people that we took to emergency departments was 74%. So in 8 years, that figure has actually gone down 11%. Our challenge is to take it down a further 9 in the next 5 years. Yes, that's challenging, and yes, it relies on joint partnership working. It is not totally within our gift to do this on our own, and we've been very, very clear about that with our colleagues right across the system and with our commissioners. But we do believe it's achievable. It is built on some very solid modelling, which is highlighted in a lot of detail in the document, and we would encourage anybody, frankly, who wants to challenge us and wants to understand more about where those numbers have come from, to come and talk to us. Angela Fati is in the second row here, is our Director of Strategy, and she would be delighted to get involved in the PhD thesis that has indeed sat behind this. It is challenging, it is ambitious, we can't do it on our own. But I think it's right that we set ourselves this sort of challenge, and it does need to come with a new way of funding services, a new way of defining the contract. But that's coming anyway, because we have an entirely new different operating model in terms of the ARP performance standards. So it's an opportunity.
But we can come and work with the Patients Forum on taking you through it as we go forward. I can assure you the board looked at it, the non-exec side of the board, with scepticism, as you have, concern, and we've looked at the detail, and we are convinced that this is the way forward. But we want funding to be given to us differently and to be rewarded differently. And as Garrett said, we have a timing slot to do that, and that's about now. So we have to get on with that. I'm going to take one more question at this part, and then we need to move on to mental health. Otherwise, our partners will wonder why they came. So, Pauline.
Hello. It's just briefly, it's about the composition of the actual board, because it doesn't seem to be representative of BME people in London. Surely there should be a different mix on the board. And when are you planning for that mix to take place?
Okay. So we have an associate director, non-exec director, who is from a BME background. One of Garrett's wider executives is from a BME background, and we are currently seeking to recruit a new member to the board as the medical non-exec, And I did put an ad. I'm not allowed to advertise because we're not a foundation trust. I have to let NHSI do that. But I did put a notice on LinkedIn saying that we were seeking to recruit a non-exec from a disadvantaged background. And I had a number of responses, and a couple of those have actually applied. So we are looking to do that. But we are very mindful that we need to represent, show the leadership from the top. Work in progress, again, I'm afraid, no quick fix to that. Thank you. Now, without further ado, I would like us to move to the second part of the agenda, where we're going to focus on mental health services. And to begin that, to give us the perspective of the national picture, I'm delighted to introduce Professor Tim Kendall, who is the National Director for Mental Health at NHSI and NHSE. Tim. Thank you.
Thank you. Hello, everyone. I'm the National Clinical Director for Mental Health. There is a National Director as well. Now, how do I get to move on? Okay. Now, for years, I'm sure everyone here at least will have some idea about this. For years, if you've got a mental health problem, you go through one door. If you've got a physical health problem, you go through the other door. When you go through the mental health door, everyone forgets about your physical health. And if you go through the physical health door, everyone forgets about your mental health. Now, there are some serious consequences to this. So if you go through the physical health door and you're not aware that you have any mental health problems, but you're going in because you've got pelvic pain, because you've got headaches, or because you've got abdominal problems, and they investigate you, and they can't find anything wrong with you, so they think, let's investigate a bit more, maybe do some exploratory operations or whatever. Currently, that is costing 2.5% of the entire NHS budget, okay? And that's because people in physical health don't understand mental health. If you go through the mental health door, currently, men diagnosed with schizophrenia will die from cardiovascular disease, diabetes, chronic obstructive airways disease, average age 60. 22 years younger than the rest of us. So there are real consequences. Now, there's another consequence which I think affects all of us, which is stigma and discrimination that happens in here. And currently, it's the number one issue that I think most people with mental health problems face, which is that they are deeply stigmatized and, unfortunately, self-stigmatized. So many people with mental health problems, I'm afraid, don't think quite so much of themselves and are rather ashamed. Now, that affects everybody in the room, including me. I work in a service for homeless people with mental health problems, and I'm very fortunate to be able to work with a group of GPs who will help me with all the physical health problems that I face. But I feel rather ashamed that I can't do that. And that, again, is a part of one of the consequences of having these two doors, not just for delivering healthcare, but for training people. So, what I thought I'd do would be to give you a very quick tour about what's happened, what we've been doing in NHS England in particular. I'm not going to say much about NHS improvement, about what we've been doing to address some of this problem by evening things out. So the first bit of that is the 5-year forward view for mental health, and I'll say a bit about that, some key bits that we've done in it, and maybe if we got time at the end that we could say a bit about what the long-term future is. But I've picked out some stuff that might be relevant specifically to you. So the first one, this is about timely access. So what does a good quality, timely, 24/7 expert response for people experiencing mental health crisis require? And you'll see from that, it could be, it's tons of different things. And that's a graphical representation, if you like, of this. So you could dial 111, or you could go to your GP, or you could or you could get picked up by the police, or an ambulance called. You could go to a crisis team, or you could just toddle up to A&E. So at the moment, what we provide is a very, very fragmented response to people with with mental health problems. And what's even more peculiar is if you go onto NHS Choices, it doesn't tell you really what to do in terms of connecting with mental health services. It tells you the number of Samaritans of voluntary organisation. Very strange. Okay, so this is what I think it's like for people who use mental health services in a crisis, and it's almost certainly going to be like that for most of you in providing a response. You'll be thinking, my God, this is a mess. So our big challenge in the 5-year forward view was to try and make it around crisis, was to try and make some sense of that. So what we've wanted to do is to get as the first port of call. So after you've gone in through your 111 or single point of access, that your first provision of healthcare is a crisis team. Now we've been suggesting that since 2001. So the 5-year forward view has reiterated that, and the new long-term plan will go one step further. And I think I'm going to skip a few of these to get to where I think we need to be. Okay, so the second thing that we're going to do, apart from providing crisis teams, is, and we're already doing this with rather more success, is to get A&E skilled up to be able to receive people effectively who need mental health care. So what we've done is invested probably in the region of 30 million a year over a period of 5 years, which is going into A&Es to provide 24/7 response. Everybody is meant to provide, all services should be a 24/7 response. But because we have problems in recruiting and we have workforce issues, we don't expect to have more than 50% of A&Es having a core 24 response, which basically is a consultant-led response in A&E, consultant psychiatrist-led response. So, and I think, Sean, you might be talking a bit more about that, so I'll move on from that. Okay, so that's what's gone in, and that's the areas that we've covered with Liaison, with sites that we've invested into so far. Now, one thing that I wanted to end on was what's happening in one part of the country, which is down in Cambridgeshire and Peterborough. And I've been there. It is a fantastic response. You phone up 111, and they triage that. They have people in the room who can do mental health work, and they signpost them to the right area. Now, before I came in, I was talking, I think you're the only ambulance service which has mental health people routinely in your able to provide this. Now, I think if I was going to say, what is it that we need to do more than anything else, apropos what I said at the start, is integrate mental and physical health. So if somebody with a mental health problem turns up in an ambulance service, that there's enough advice there for people to be able to deal with it there and then, and not necessarily take everybody to A&E. So that's what they're doing in Cambridge and Peterborough, and I think they've got some very good results. So, without further ado, Sean.
Thank you very much. So, you're going to introduce yourself, Sean. Go on. All right then. Dr. Sean Cross, who is a consultant liaison psychiatrist, is going to talk to us about Liaison. Thank you.
Thank you very much indeed, and good evening, everybody, and thanks very much to Tim as well. So I'm one of the liaison psychiatrists that Tim has just been talking about, and work just down the road at King's College Hospital in Denmark Hill, and I'm going to speak to you for 5 minutes only, and with no slides, so you can look straight at me without having to kind of look at the back. So, liaison psychiatry, as Tim inferred in one of his slides, is a relatively new group of individuals that are trying to do this thing of bridging the gap between mental and physical health care. And so I work just down the road. For those of you who know, the number 68 bus route, Denmark Hill, running straight through South London. One side of the road you have King's with a helipad on the top. On the other side of the road, one of the most prestigious institutions in the world, the Maudsley. And of course you have a giant piece of tarmac between the two, which is a brilliant metaphor for all the stuff that Tim has just been talking about. And in my most depressive moments, of which there have been many recently, I think I do little more than help people cross the road. And pretty much that's what my service is trying to do. Because what we're trying to do is knit together, in a very operational way, different parts of the system, different parts of our siloed system that many people have been talking about this evening. And so I just want to do three things in my 5 minutes. I want to reiterate why this is important. I want to talk to you a little bit about some of the very detailed, granular service changes that we're piloting in King's that may be of interest to people. And then the third thing is to talk a little bit about education and training, because I think that's key to many of the culture change ventures that we are all engaged in this evening. So first, why is this so important? As Tim has been saying, there's a dreadful mortality gap between those of us who have severe and enduring mental health problem and those of us who don't. 22 years, 15, 18 years, a large number of different studies showing different numbers, but there is a significant gap. And it's not just mortality, it's also morbidity. So those people those of us with schizophrenia, those of us with schizoaffective disorder also end up using crisis services more regularly, end up having all sorts of issues around their own physical health care, whether it's cardiovascular disease or other problems, and then they go into a service, into a national health service that does that thing that Tim so eloquently described, and you go through one door or the other. Joining up, matching up, so that people are able to experience what is basically just integrated holistic care, a human being treated in front of them. And no matter where in the healthcare system this gets played out, bad things end up happening and poor outcomes end up being the result of it. And locally here in Lambeth and Southwark, I'm clinical director of what's called our Mind and Body programme, which is our attempt across King's, Guy's, Tommy's and the Maudsley and the university, and increasingly out into primary care as well, to try and do something about knitting this together. The second thing I just wanted to mention was, in addition to this increased amount of funding that we are getting from the government around liaison services, which is a good news story, at a time when there's very little in terms of good news stories nationally as far as health, as far as our NHS is concerned. There are other initiatives that we're trying to sort of understand and push to improve on as well. And I'll give you a couple of examples of those. If you're a paramedic and you enter into King's, where I've come from earlier today, and you bring someone with a mental health crisis or a mental health problem, then all these issues that we're talking about are, occurring all the way around you. There have been for many years, when I worked at King's, and I worked there with Bryony, who's responsible for me being up here this evening talking to you, a very sort of odd thing happened when you ended up in A&E, in this sort of rather sort of sequential series of events. Someone would check you in, then someone would take the handover, then someone would take a history, then at some point someone would look for mental health services to come and do an initial assessment. And yet if you came in via a trauma call or something like that, quick, smart, everyone together right at the front, and we actually have a trauma call bringing everyone to the front of the care pathway. Now we do the same with mental health, and we are piloting something called Code 10, which basically is something really very simple, which is that if you come in with a mental health crisis and you come in with all the kind of issues that we've been talking about so far, then actually you just bring everyone together right at the front of the care pathway. So you bring liaison services together, you bring the nurse in charge, you bring the consultant who's on call together in the same way that you would if someone was having a major physical health crisis. And it doesn't solve everything, but it tries to address many of the issues that someone would experience over many hours. The other aspects of trying to address this problem at King's is trying to look for the problems when people don't see it. We're talking about a workforce that has been trained to think just about physical healthcare or just about mental health care. And so we have a big screening program as well, where we actually look for problems in terms of mental health on the acute side of the road and physical health on the other side of the road. And the third thing is, over the last year as well, I'm incredibly proud of the way in which mental health services also responded to the major incidents and crises that we had. And it's increasingly recognised that it's not just having to respond to those people who've been caught up in the incredible nightmares that they were last year, but also thinking about our staff and the way in which mental health services are able to respond in a way to bring about culture change in an organisation that can look after their staff in a way that was so necessary last year, and I'm sure will be at some point going forward in the future as well. And the third thing that I just want to wrap up on is around the vital importance of education and training. And not just education and training across core competency frameworks. If I'm a paramedic, I will train here. If I'm a doctor, I will train here. If I'm a nurse, here. What I'm really interested in, and one of the reasons I'm here on a Tuesday evening, is because I'm really interested in crossing boundaries and crossing borders and working across silos. And there are a number of initiatives that we are engaged in with the world of paramedics. And I run a simulation training program, which Bryony has been involved in a great deal as well. And sim training, for those who don't know it, you may well be used to it in terms of using mannequins. We use a lot of actors. And we are an award-winning team down at the Maudsley, BMJ National Education Team of the Year last year, because we focus on training across care pathways and bringing together those who work across care pathways rather than bringing together individual professionals. So I'll give you an example. We have a number of simulation training courses where we take someone in crisis. So that means the people who are on the course are a paramedic, a police officer, an A&E sister, a consultant in A&E, and some mental health workers. What we do is we bend the education and training around the pathway that someone is experiencing. And not only that, but when you do sim training, when you're replicating something that occurs in real life in an amazing way, like a little TV studio or in A&E departments themselves, what you do is you get people to act, think, behave in the way that they normally would, and it enables you to have conversations that are vitally important, not just in the stuff that Tim has been talking about, but the stuff that has popped up in other bits of tonight's AGM. Stuff about addressing things like care and compassion, addressing things like institutional racism, and how that can play out in an individual care pathway. And so education and training is something that I feel very passionately about. We are embedding in the St George's University undergraduate paramedic course, which is great, bringing on mental health training there. And we have run quite a few now, around 20 of our day-long courses, bringing together members of the Met and the LAS together with our mental health workers to look at many of the issues around dealing with people with crisis and mental health care problems in our emergency services. So it's incredibly important. There are amazing things going on, and I'm very happy to chat to anyone about them if you want, and the real importance of education and training. Those are the three things I wanted to leave you with this evening, and thank you very much indeed.
So I'd like to thank Sean and Tim for very much setting the scene for what now is going to be how we're moving forward with mental health services. And could I invite Carly to come up to introduce the next part of the programme. And Carly is our mental health lead at London Ambulance Service.
Hello, good evening everyone. As Heather said, I'm Carly and I'm the current mental health lead here at London Ambulance Service. I'd like to introduce a series of films to you now which have been made by a group of service users that we've had the privilege of working with in the Oxley's NHS Trust. They're a group of patients with lived experience who've come together to share their experiences, both positive and negatively, about when they've called 999. We've also been working with them closely to provide training for our student paramedics on our in-house paramedic programme, and they've also produced a side of a pocket card that will soon be produced. As you will see from the films, a common theme, and it's been touched on this evening, is the importance of small moments of validation during patients in a mental health crisis, and this can have a huge impact on their recovery. So let's hope the videos work.
1 second.
Although what happened wasn't good, because I was just at my lowest and I was in this flat on my own. And I was going through thoughts I just want to do something to myself, and I got a lighter from one of the girls in the hospital and I brought it back home and I had some nail polish remover and I set fire to the bed because I thought I just wanted to end it all really, and wasn't thinking about other people being there. My mind was just in such torment. I thought this is the best way. If I die, then there won't be any more pain. But when I actually came to think this is quite wrong, and I panicked really because I thought the door's going to stick because of the fire. So I ran next door to the neighbours and I just explained there's a fire, and they dialed 999 and they were really helpful, and the fire brigade turned up and they were so nice to me. They sat me in the back of the fire engine, put a coat on me, and the neighbours were trying to keep me away from where the fire was. They were really good. Even when my dad went round, they were asking him how I was. And they said, we heard her crying most nights and we didn't know what to do. Because they made me feel that I wasn't bad and I was just in a bit of a bad state. You know, I was going through a bit of a trauma and things would get better. And they did say to me, you know, there is light at the end of the tunnel. You know, you will get better. You won't feel like this forever, and just... you can't keep doing this to yourself really, it's not good for you. And I think that made me feel like I was a bit more important and I felt like I was worth something.
2 ambulance men arrived. One was acting in a more senior manner than the other, I guess, so he was asking my sister the questions. And from what she tells me, they checked my pulse, they flashed a flashlight in my eyes and sort of across my face, asked my sister what had happened. She said that she wasn't sure. She thinks I'd taken all the beta blockers and that I'd basically told her that I'd wanted to die and asked her not to ring an ambulance, that I was definitely sure that I wanted to die. The ambulanceman turned to his colleague in front of my sister and said that she's doing it for attention, she'll be fine. My sister at this point burst into tears. Other ambulancemen again shone the light in my face and across my eyes and happened to notice that my lips were turning blue. From what I understand, from what my sister tells me, the journey was very quiet. She wasn't spoken to by the ambulance men. They didn't tell her what was happening. They let her know which hospital we were going to. But the 2 things I took away from the whole experience that I was able to recall myself at a later date were being told that I was attention seeking, or my sister being told that I was just attention seeking and that I would be fine. And I remember being asked if I could walk down the stairs and I said no, and they said make her do it anyway. I think for me personally, the reason those 2 phrases stood out, even though they weren't being spoken to me directly, is because it reinforced every interaction that I had had with an A&E or an ambulance previously through self-harming or attempting to take my life. It just reinforced everything I felt about being worthless and a time waster, and it would just be easier if I wasn't around because all I did was waste people's times.
Yes, I mean, I had to phone the ambulance, but I personally didn't think they were going to do anything. So in my mind, I still believed that actually that was going to be my last day on this planet. He talked to me about why I'd called them, how I was feeling. He then he took my blood pressure, which had gone off the scale. Yes, I mean, it's very clear that obviously my blood pressure was rocketing high. I got a mental health condition. They talked about both, but it very much became the primary problem was the blood pressure at the time because they were there, I was safe, etc. But what was important to me, and what I remember to take away from that, is the fact that at all times, their demeanour never changed. So it wasn't like, oh, you've got a mental health problem, oh my God, your blood pressure's sky high. It stayed so professional. But also when we got in the ambulance, me and the guy and my neighbour who were at the back were like laughing or remember, like, talking about the fact that we were going over Hump, these sleeping policemen, and how uncomfortable it was, and how I was grateful that I wasn't in the ambulance with a bad back. The reason that matters to me is the fact that I've been treated like a person, a human being. I was being validated. When you're in crisis, you're thinking you're worthless. You want to die. You want to give it all up. So when someone actually validates you and treats you like, you feel like you're worth something.
Does anyone have any kind of comments or questions about those videos? Because I've seen them a few times now, and to me they're quite powerful, and it just reiterates not to lose the human touch of care. And the group are very committed to, through negative experiences and positive experience, in kind of, working with staff and providing education. And we're going to talk now about our mental health pioneer service. And I met with the group last night, and I'm pleased to announce that they'll be providing some training for the car before it's launched. So can I invite my colleague April up too? So first of all, I'd just like to say how proud I am to work for an organisation that is really committed to improving the experience of mental health patients in crisis. I'd also like to thank my mental health team here, two of which are in the audience if you'd like to wave, because without them... Without them, none of this would be possible. And I also want to thank my paramedic colleagues and other colleagues who've been fully supportive of the pioneer services. And again, without their input and support, none of this would be possible. So I'm just going to talk to you a little bit now about the context of kind of mental health calls to the London Ambulance Service. So as you can see on the slide behind me, last month we received 13,044 calls for patients presenting with mental health needs. We sent a vehicle to 8,899 of these, and 4,000 received advice over the phone by some of my colleagues here. 7,698 of those patients were conveyed to the emergency department, and we attended to 102 patients who were detained under Section 136. As I've touched on, we have a dedicated mental health team, which is comprised of 7 senior nurses who provide support over the phone, training and education to our colleagues. And I'm also here to talk about the new strand to our role, which will be our mental health car. So in November of this year, we'll be... Oh, sorry, I'm not very good with computers. We will be launching our mental health pilot, which will see a mental health nurse and paramedic working together on a car responding to patients with mental health needs. This will ensure that mental health patients have both their physical and mental health needs met, and some of my colleagues have touched on the importance of that. And we want to ensure that we provide the right care first time to these patients. We know sometimes that going to the emergency department absolutely is the right thing for our patients, but sometimes there are more alternatives that we can look into, and my colleague Elvia will be talking about that afterwards. To me, multidisciplinary working is crucial in providing these benefits, and we can't do it in silo, i.e. just a mental health nurse or just a paramedic. I've had the privilege of conducting 5 pilot shifts now with April and some other colleagues, and we've been able to divert all of those patients away from A&E and put them onto a more appropriate care pathway. And we've learned a lot from each other, and April's going to talk now about that.
Thank you. So I've been fortunate enough to undertake 2 pilot shifts with Carly on the mental health car. And it really is a collaborative approach. So I'm there with my paramedic hat on, trying to address and assess the patient's physical health needs, and I don't think these should be underestimated in the acute setting. These patients often present with sometimes drug overdose or use of recreational drugs, self-harm, so it really is important to have that physical health assessed. And then Carly's there obviously with her mental health and her expertise in that area. After each patient contact, Carly and myself would get together and we would reflect and debrief to sort of think if there's anything we would change or do differently. And I think we highlighted that around 3/4 of the patients that we attended, if Carly hadn't been there, I would have felt compelled to convey not having Carly's skill set. And on the other hand as well, I think, I speak for Carly now, there was a few of the patients that you would have felt compelled to convey to A&E had it not been for a physical health assessment that we could provide on scene.
Is there any questions about that? Hello.
Thank you. I think the last patient there, what he said is so important for all of us. He felt he was being validated by the staff who turned up to attend to him, the London ambulance staff. And that's the whole thing about responding to the patient and then taking into consideration whether it's a physical problem or a mental health problem. But you have to identify with the patient that this is a human person you are dealing with, and then you'll be able to respond and know where the appropriate care to take the patient to. So we are very grateful. Thank you so much.
Hello, and I'd like to invite Elvio from the Recovery Cafe in South West London. Oh, sorry. Oh, yeah, of course, yeah. Sorry.
So there we go. So good evening. Thank you very much for that. So I work for Health Watch Southwark. So actually this is a... Hello, Guinea. It's a really, really good area to be in. So one thing that I'm intrigued about is where... You said that there are 5 people and you diverted them all away from A&E. So I think a lot of times we're actually doing a project on mental health crisis, and a lot of them have so far said that, you know, that at 11 p.m. that they've gone to A&E, and at that point in time we're looking at where in the community that people can go to. And of course, there'll be very, very few places. So I'd be very intrigued to know where they went, or if you know.
So the patients that I've seen, I completed a clinical assessment and I kind of effectively brought what would happen in the A&E department to the patient, whether that was at home or in the street. And then I was able to, if it was out of hours, liaise with the kind of mental health on-call services, which are obviously, you know, it's different in different patches, but something we are keen to do as an ambulance service is develop our links with kind of, you know, voluntary and services, which Elvio is here to talk about.
Good evening, everyone. Thanks for introducing me, Carly. So I'm Elvio Correa. I'm the service manager for the Hestia Recovery Cafe in Tooting, and I'm going to very briefly, in the space of 5 minutes, provide an overview of the Hestia Recovery Cafe and what we do with our service. So the Hestia Recovery Cafe opened in April 2017, commissioned by South West London and St George's Mental Health NHS Trusts. We are a service for residents of the 5 West South London boroughs of Richmond, Merton, Wandsworth, Kingston and Sutton. For adult residents who are 18 or over who are struggling to cope with their mental health and who need support at times when other services may be closed, and who may lack the social networks, resources, or may feel suicidal or inclined to self-harm. We are essentially an out-of-hours service, and importantly, we are open Monday to Friday, 6 p.m. to 11 p.m, and weekends and bank holidays from 12 o'clock noon to 11 p.m. So we have opened in April 2017 under the leadership and the guidance of the NHS, of the trusts, and the majority of our customers do come from Wandsworth, but we do have significant numbers of customers coming from the other boroughs, in particular Merton Very briefly about Hestia, we are a large third sector organisation that provides a range of services across London and the South East. So not only mental health, within mental health we do provide a range of services, but also services for domestic abuse, modern slavery response teams, services focused on other people, young people, people affected by disabilities, and offender services, or ex-offender services. In terms of the Hestia Recovery Cafe, so I will go through the main features of the cafe. So essentially we provide access to information and support, so it's advice, information and signposting to a range of other services. It is also a key way in which we reduce dependency on the service. So customers may present to the cafe, there's no need for referral. And we do an assessment initially, informal assessment. Advice, information, signposting are things that we provide. That could include signposting to services such as befriending, housing, welfare benefits, advocacy, and importantly, an organisation who we work in partnership with called the Listening Place. I don't know if you've heard of the Listening Place. They provide support, which is counselling-like type support for people who may be feeling suicidal. We also provide one-to-one sessions with staff, senior recovery workers. And our conversations there are very much focused on strengths. We provide, also being a cafe, healthy meals and hot drinks at a minimal price. We importantly provide an alternative to A&E, including the aim of trying to reduce ambulance call-outs. Key ways in which we do that are through the one-to-one sessions and safety planning, partnership liaising with the Listening Place that I've just mentioned. We do have protocols that we have to follow, and that again, we work very closely with the trust around these protocols to deal with self-harm. We also work with the home treatment team very closely, who visit the cafe every night and who are available to provide further advice, information and support over the phone. Sometimes we may ask them to carry out a formal assessment. However, the number of formal assessments that we have carried out at the cafe by the home treatment team is quite a reduced number. We provide groups and one-to-one sessions as well as one-to-one sessions. And in terms of groups, we do provide a wide range of activities at the cafe, again, therapeutic activities, the majority of which are facilitated by our volunteers. So volunteers form a key part in which we deliver the service, but we are, of course, a team of senior recovery workers with a minimum of 2 staff on shift. So in terms of the group activities that we offer, it ranges from art therapy to creative writing to yoga. We've got Zumba. We have cooking sessions. We have a range of activities at the service, which we keep changing, refreshing, and using ideas from people attending the service. So it is essentially a safe space for people struggling to cope with their mental health, providing having a capacity to see 25 customers. We call people attending the cafe customers at any given time. Encourage the average attendance at the cafe of 22, so 22 attendances per day on average. So in terms of our shared vision here, it's essentially around making sure we have a space which is accessible, which is welcoming. The Recovery Cafe is quite a big building, having different areas. So we have a main hall, we have an IT suite, we have a quiet area which can be used for meditation. We have a front room, which is a comfortable space which can be used for one-to-one sessions and assessments with the home treatment team where needed. We do provide healthy foods at a low cost. It is essentially co-produced with customers. And it is focused on strengths and developing support for networks, and focused around reducing crisis, worry, and anxiety. As I mentioned, the team are a team of 4 senior recovery workers. We have a full-time dedicated team manager at the service, so majority of the occasions we have a team manager on site. Also tend to be on site, we tend to alternate shifts. And as I mentioned, we have support from local home treatment teams, primarily Wandsworth and Richmond home treatment teams. Co-production is another key aspect of which we run the service. So right from the outset, the whole concept, planning and procurement process, the Recover Cafe involved service users, and currently 2 service users attend the Recover Cafe contract meetings with the trusts. But our co-production is much broader than that. It includes community meetings which are attended monthly by different customers. Includes a range of methods through which we collect feedback to further improve and develop the service. And what is interesting, I think, as well, is that co-production and involvement was recognised by the Trust's Service User and Care Involvement Plan, where the Recover Cafe was identified as an example of good practice. We do receive a lot of compliments, and that is in stark contrast to the number of complaints that we receive. So we receive very few complaints, and the number of compliments far outweigh that. And I've decided to include a few quotes there about what people said about the cafe. So I'll read one to you. So I have found the Recover Cafe incredible. I have become more confident in sharing my problems. Group activities are highly inspiring. Another person said the cafe has helped me immensely. It is my safe space. Another person said the cafe has really prevented me from going into crisis. That's essentially it. Yeah. Thank you.
So if I could thank Carly and her team and Elvio for, I think it's been a very insightful journey into mental health and how it can be very different from the A&E experience. And anybody who's worked in an A&E or taken a patient with a mental health problem to A&E will know that the patient gets stuck in a little room if they get attended to. Big, burly security guys turn up, and the whole situation becomes far more anxiety-provoking for the patient, and it gets out of hand. So when we had, it was actually the last client who was talking on the video about going over the speed bumps. We had that video, a bigger version of that, at our board meeting, and that was the first I'd heard of something like Hestia. And we said, well, can't our crews take patients, clients? People tend to be all in crisis, probably patients. Is that right? A patient when in crisis, is that fair? But clients normally for mental health. To a cafe that's supportive, that avoids going to A&E is tremendous. And we've now got agreement, have we not, Fenella?
We're very close to signing the agreement. We're just waiting for the final governance bits to come through.
So our plan is to be able to work with our mental health teams and our partners to be able to do the different pathway, which is better for patients. So I think that's been tremendous. At this point, are there any questions about the mental health, what you've heard about the national policy, liaison psychiatry, which I have to say, when it first started, when I was a mental health chief exec in the early 90s, it was considered to be the easy bit of psychiatry as opposed to the essential bit of psychiatry, and how times have moved on, or about our own services. So open to questions. Pauline.
I've got a question from our social media channels. As you know, we're live streaming at the moment on YouTube, and we've had people watching who have sent in some questions. And there's one of particular relevance, which is, what is London Ambulance Service doing to help and support staff's mental health?
That's a very good question. Patricia, do you want to answer that? It goes to people, and they do, but it's something we're very mindful of. And I did see earlier Jules, but I can't see her now, who's also done a lot of work with us.
Yes, so a number of different things, and again, it's one of those things that doesn't stop. So we have our peer support network, so members of my team with our paramedic colleagues who are trained to give that first port of call, that listening ear to our own staff, and also more advanced trauma support as well, when they've been dealing with the more difficult incidents and some of the major incidents that we've heard about. We've also got extensive services through our partner, PAM, where members of our staff, not only for physical support, but also can get mental health support. So direct access to counselling services through that organisation, and with the intention of actually providing those services close to where they live or close to where they work. So there's a whole range of different services that people can call upon, members of our staff, our colleagues. Thank you. Sorry for that interruption.
It happens. Are there any other questions? Yes, gentleman here.
Thank you. My name is James Guest. I'm a member of the Patient Forum. Two things. Firstly, following on from the last question about supporting staff, there's something I remember writing to Heather about a year ago after the various summer tragedies, and that is stress is not just current. It can come many years after an incident. It's accumulation, and this was an example of people who'd served in the Second World War, and some 20, 30 years later were beginning to experience stress. So I think there's an additional strand, which is not just serving the current employees, and we've had some very impressive presentations at the Patient Forum about that, but I think we need to be thinking, particularly as people change careers, continuity is shorter, we need to be thinking about those who've served with the ambulance service and thinking about them 10, 20 years after they've left, and also their families. I mean, things like combat stress, I believe, address that, but I do think, if I could just suggest that to be parked and thought through, it's the longer-term strand. The other one is just me being a boring, recently retired accountant. It's been really impressive hearing the initiatives, and I think one thing that came out was 7 mental health nurses in the operations centre to support the callers. But I'm trying to relate that to a 24/7 operations centre. How many staff do you need to ensure there is always one on duty, allowing for the shift pattern, training, holidays, and everybody has a little bit of sickness?
Yep.
Does 7 just mean 1 at a time?
Pretty much. That is about right. If you look at any service that you're trying to have 24/7, 7 people give you a rota of 1, assuming people are whole-time equivalents. But I think that Garrett just gave me a bit of info talking about this car. So we see we have around 100,000 mental health clients calling us a year. That's about 8% of what we do. At the moment, 60% of those will be taken to an A&E. We don't currently have alternative pathways, which is why the mental health cafe work and the work of our paramedic and mental health nurses going out in a car, not just being in the service, is giving us an opportunity to change that. And I think we would see that if you look at the best performing trust in the country that has that sort of service, they only convey about 22% to A&E. So when we're looking at our reductions overall, to your earlier question, here is part of the pathway. But you would be right. That's why we also need to be commissioned differently, because if we're going to be doing this sort of service, it has to be paid for. It doesn't come for free. And you could say, we're grateful to have 1 per shift, but that is the beginning of where we need to get to. But it's also about the partnership with the paramedics. And you heard about the physical and the mental health, both sides, both from Carl, but also from Carly. Carly, do you want to add to that? No? No? Okay, thank you. So you're right, the accountant in you is not wrong. Now, before I conclude, are there any other questions? Okay. Do you want more?
Social media channels.
Can't hear you, Pauline.
Is that live now? Okay, great. Are there new vehicles on the way, and will they be electric?
Oh, good question. Our chief exec's favourite topic.
Heather always accuses me of wanting to talk about electric vehicles all the time, and I never want to talk about electric vehicles. I think should be the job of other people. New vehicles generally on the way, yes, in considerably large numbers. The Trust Board has approved a 5-year programme of capital investment in new double-crewed ambulances, the full-size vehicles, which are conventionally powered, but are compliant with the latest emission standards that the Mayor is requiring of all traffic in London. We're just coming to the end of rolling out an initial batch of 140 that we rolled out over the last financial year, and in this financial year we will roll out another 30 fully finished vehicles before the end of this year, so that will be 170 over 2 years. We have an ongoing programme that will see us investing in a further 50 to 60 over the next 4 years beyond that. We should also thank NHSI and HSE who have supported us with some additional funding in the current year, some 3.9 million, just under, to help us accelerate that programme. The reason we need to accelerate it is because the new ambulance response programme requirements need us to put out more ambulances and fewer cars. So historically we've been, in terms of fast response cars and double crewed ambulances, they've been roughly around 50-50. We need to get probably at least to 70-30, if not 80-20, something like that, over the next few years to allow us to fully maximise the benefits of that new response programme. That means investment in new vehicles. You might think, oh, we can just keep some old ones on for longer, but A, some of our oldest vehicles are really too old, but B, because we have signed a commitment with the Mayor of London to make our fleet fully ultra-low emission zone compliant by October 2023, which is something of a let-off compared to the date for the general traffic to be fully requirement. We have to meet that date, which means we have to invest in new vehicles. So there is an ongoing investment in conventional vehicles. In terms of electric vehicles, we are currently rolling out now a number of fast response cars that are fully electric, and that is something that we can start to move to straight away. The real challenge, of course, is can we get to a fully electric or an electric hybrid full-scale ambulance. That is a big challenge at the moment, but it's one we are working very closely on, both with our other colleagues around the country and also with the vehicle industry, the Society of Motor Manufacturers and players there. We're not in a position where we can announce anything definite yet, but I think that is something we're very alive to. It's a big challenge because our vehicles are quite heavy and they use a lot of electricity in terms of the operation from a clinical perspective, never mind the electricity that will need to power them around town. And they have to operate very long hours in terms of arduous service conditions. There are opportunities to do it. We have to also take into account the charging situation, because there's no point in having electric vehicles if we can't charge them, not only at depots, but also at an A&Es, ambulance aprons, and so on. So there is a lot of work going on, but we are still got some way to go before we can get to fully electric, large-scale ambulances.
Thank you.
The funding for the mental health bus with the mayor. I don't know if you've got some money now to return the alcohol bus, rather.
Paul.
Hello. I think you're referring to the vehicles that historically we used to put on at specific peak times of the year where there was a higher prevalence of alcohol-related calls. Over the last couple of years, we haven't had those vehicles in operation, and that's for good reason. What we've preferred to do is try to educate through campaigns, particularly at Christmas, and with the increasing use of social media to highlight the concerns around alcohol, particularly at peak times. I think when we initially brought them in, we were trying to look at ways on how we could reduce the number of frontline resources that we sent to individual cases. But that's actually, as a consequence of that, it's very short-term thinking. It gave A&E departments some considerable issues, particularly when we were rolling up in a multi-occupancy vehicle and actually arriving with 5 patients under the influence of alcohol. That causes its concerns to an ED department. The other thing is alcohol masks other conditions. And so it's important that actually, when we're talking about mental health patients and validating and talking about whether we look after their physical or their mental health, we have to do the same with alcohol. So alcohol masks a number of symptoms and can mask serious illness and injury. So it's right and proper, actually, that when those patients are suffering with a condition where alcohol is involved, that we do a proper assessment on those patients and treat the underlying conditions or any other conditions that are presenting. That's why we've moved away from the use of those vehicles, and we're using much more sophisticated strategies about how we manage demand, particularly in peak times. Thank you.
Before I conclude, I think it's probably appropriate to say there are some refreshments hopefully still left. There's a networking opportunity, and I'd invite you to ask further questions to the execs or board members while we have that networking opportunity. But before I do, I want to do some thank yous. Thank you again to our external speakers for coming, and for our internal team talking about mental health and HESPHIA. I hope it gives you confidence that London Ambulance Trust is focused on the real issues facing Londoners. So I would also like to thank our executive team. When CQC came this last time, not only did they say we were good, but they recognised that we now had an executive team who had a vision, who had a clear strategy, who had the skills and competencies to deliver what is a very exacting agenda. So I would like to thank you all for coming, thank our external speakers, and take the opportunity to congratulate our internal team as well. Thank you.